preface everything to say that I'm frequently asked, are you serious about expanding Medicaid in Texas? Not like, are you seriously determined? Do you seriously think it can happen? And the answer is absolutely yes. We are not just closer than we've ever been because we've never been close. We're actually close. I can't predict that it will happen this session, but it's so possible if we can get the right message out to enough people in a timely fashion. So I'm going to run through the message now, and then I'll be happy to take a bunch of questions. There it is. Can you all see a slide that says expanding healthcare coverage in Texas?
Yep, you're good.
Okay, great. And the reason it says expanding healthcare and coverage in Texas is because some people are afraid of the word Medicaid expansion, and many of them happen to be called legislators. Not all of them are concerned about those words. In fact, voters, constituents largely aren't, as polling shows throughout the state. But it is still very difficult to get, and I'm going to use words like Republican and Democrat here. And ultimately, I'm hoping that those words collapse around this issue. But at the moment, there's still a bit of difficulty for Republicans, particularly those who have vocally opposed Medicaid expansion, to get on board with anything called Medicaid expansion. Reality check here, whether you're talking about straight Medicaid expansion, what's called a state plan amendment in the fine print here, or an 1115 expansion waiver, which many states in this country have done, especially Republican-led states, which is a special permission to do Medicaid expansion with a little more flexibility, or add things to it. Either one of those, or a third way, which the Trump administration introduced, his healthy adult plan or whatever it was called. It was a block grant, but it was still Medicaid expansion. What we really mean by Medicaid expansion, even when we're not saying those words, is what's here in the fine print. We mean expanding coverage to adults age 19 to 64 who earn less than 138% of the federal poverty level, critically important element at a 90-10 state match. There's nothing out there where states can leverage their healthcare dollars at a 90-10 match except an Affordable Care Act coverage expansion. That's it, no alternative. So we don't have to call it Medicaid expansion. We can call it coverage expansion. We can call it the Live Well Texas program, which is what I'd like to call it because that's what's in my bill, or somebody else's bill, as long as it pulls down 90-10. And I have a whole slide on this later. But if you remember nothing else today, it's that we got to get a 90-10 match. Just tell your legislator, we need a 90-10 match. Why? Because it makes money. So we'll get into all this. First, the problem. If you're still watching at this point, you're probably already aware that Texas has the highest uninsured rate in the nation. And I just find this slide striking, even though I knew that. When you see it graphed out, I chuckle because of how absurd it is. We're way behind. Now, a full-blown Medicaid expansion or ACA 90-10 coverage drawdown is not going to pull our graph down to match those of other non-expansion states. We have other structural issues in Texas that is having a high uninsured rate. There are other things we need to do in addition to Medicaid expansion that pulls our rate down. But it's the single largest chunk of people that we can provide insurance to all at once. So it will have a market effect on this graph. So it's a big problem, particularly in Texas. As you can see on this slide, these are income eligibility levels. Let's start with that 19 to 64 population that is not elderly, is not a child, and is not pregnant or disabled. If you're in that category and you earn more than, it doesn't matter what you earn, I was gonna say more than zero, you cannot qualify for Medicaid in Texas unless you are a kid, a senior citizen, disabled, or pregnant. That's a lot of people that don't have coverage. If you are pregnant or, a mother, you are eligible, a mother or father, if you're a parent, you're eligible for Medicaid if you earn up to about 16, 17% of the federal poverty level. That's right, about an eighth of the amount of money that everyone agrees you cannot survive if you earn. That's the poverty level. It's really, really stringent in Texas. We've got to fix that. So you see that big problem. You see part of the reason we have the big problem, and takes me to my overall statement about why is Medicaid expansion or ACA coverage drawdown right for Texas. It has been proven nationwide to improve public health, increase family financial stability, decrease visits to the emergency room because people aren't relying on the emergency room as their first source of care. reducing smoking rates, stabilizing urban and rural health systems, many other benefits. It's really effective, as we've seen throughout the nation through the other 38 states that have expanded, a couple dozen of them having expanded maybe half decade or more ago. So we've got good data to show that this is working. Next, it has a net positive effect on the state budget. We've heard for years that Texas cannot afford to expand Medicaid. Many, by many I mean more than two, more than three, four, many just recently, and I will say many generally, people have examined the fiscal effects of Medicaid expansion. In other states, overwhelmingly what we've seen is at worst a neutral effect, in many cases a positive effect. In Texas, the recent studies have predicted that on a purely static basis, meaning not taking into account the economic stimulus of Medicaid expansion, just looking at pluses and minuses in the budget and revenue, it actually costs us about nothing to expand Medicaid. That's on the conservative estimates. The only slightly less conservative estimates say we gain $100 million for a Medicaid expansion. Now, when you factor in the fact that there's an economic boost for Medicaid expansion, you add to the state budget by billions. We'll get to that later too. Then finally, it boosts the economy. When we expand Medicaid, we pull down 10, 11, 12 billion dollars per biennium. That's 5, 6 every year because we have a 2-year budget cycle. And that money comes into our economy for the first time. It's brand new money coursing through the system, which, as we've seen in every other scenario, when you have inject money into the economy, it stimulates the economy, it creates jobs, it increases employment, increases productivity, all the wonderful benefits that come from an economic boost. That's why it's right. We've been through those 2 slides. Now, on that money side of things, you're going to get people saying, nah, you're not going to give people health insurance for free and make money off it. And you say, we are. That is because we're comparing 2 programs where we partner in a partnership with the federal government. Under our current grossly inadequate system, there are many things that we are paying for with state dollars, either at 100% or at a less favorable federal state match rate. When you move over to a Medicaid expansion, many of those programs that we were paying for 100% with Texas dollars are going to be paid for 100% with federal dollars. Or if we were paying for them with 40% Texas dollars, we'll pay for them with 10% Texas dollars. That's the little savings bubble over here. That's a lot of money added up very quickly, maybe $600-700 million in a year. Also, there's a revenue component. Because Texas has an MCO, a managed care system, we contract out to private insurance providers for our indigent healthcare system. Every Medicaid enrollee has an insurance policy from the private sector. Every one of those private sector policies pays a little tiny tax under current state law. If you add 1 million new enrollees, which is about what we project would happen were Texas to expand Medicaid, you have 1 million new insurance policies paying that little tiny tax. That little tiny tax adds up to a couple $100 million in revenue for the state over the biennium. So the savings we just talked about, plus that revenue, is more than the projected cost of providing health insurance coverage to this 1 million people. It's actually not that complex. Now, we were talking earlier about the economic boost, we're at like 0 on that static basis, just savings plus revenues greater than costs. Or we're at like favorable in the black $100 million. Pretty good deal. Oh my gosh, we've actually helped 1 million people and we made some money or didn't lose money. Pretty good deal for the government. Now add the dynamic revenue. Again, $5-6 billion a year coming into our economy, churns the economy, revs the economy up. That results in greater local and state tax revenues. $2.5 billion in state revenues, the latest estimate. $2 billion in local revenue. We're talking about counties and cities that need money. So it's a good deal. This is a slide that I include because it's from one of the studies that examined that static basis I was talking about. This is a slide from a study that looked at the dynamic effects that I was just talking about. These are done by people who've worked in the public sector, who've worked in the private sector, who've worked in academia. They know what they're doing. And the interesting thing is, unlike many issues where you'll get experts disagreeing with each other, the experts agree with each other on this subject. The disagreement is coming from people who are motivated. And we can talk about some of them in probably the Q&A, I suspect. I, at one point, asked one of the economists, how much have we lost already by not doing this? And this slide is an attempt, I won't go through all the numbers, but had we done this a couple of years ago or 4 years ago or 6 years ago, we could have had enormous benefits. And this slide estimates what some of those might have been, how much money might have been spent in the private sector, how much increase, how much the state gross product would have increased, how much personal income would have increased number of jobs, reductions in morbidity and mortality. Those are good things. So many good things can come from this. You got to work really hard to oppose this. Again, we'll get to the attacks later. What I started off at the beginning, I think bears reemphasizing, particularly in the political context. And if I'm talking to you as an advocate, as you being the advocate, you're going to run into people that say, yeah, look, I mean, the Medicaid expansion, you know, that costs too much. No, it doesn't. Yes, it does. Okay. But and so you can't agree with people. And so they say, well, let's do something. Let's compromise. Let's meet halfway. Let's find an alternative. There is not one. This is it. This is the 90-10 match. This is the only way. Those magic numbers of it making money for the state relies on the 90-10 match. There is no alternative. The alternatives are not whether to expand Medicaid under the ACA. You can have alternative names for it. The true alternatives are in implementation. Are you going to have health savings accounts? Are you going to have work requirements? There's a lot of different things you can do in how you implement the program, but the program is the program. 90-10, got to be 90-10. The other problem with less ambitious programs is that they typically address a very small fraction of the overall, not just of the population of the uninsured, they address a very small fraction of what an expansion would address. You can pick up 1 million people. Some of these alternatives pick up 50,000, 100,000. Yeah, that's great. It's really good for those people, and I'm all for it. And I would support it. But it's not an excuse for doing what we need to do here because it's so small. Secondly, it's going to fail. It's not going to pass the legislature, or it's going to be an act of hypocrisy if they can't afford it and then spending money on it anyway. What am I talking about? All these alternatives, 60-40, not 90-10. If it's 60-40, that's 40 local property tax dollars that's got to be put in instead of 10 general revenue dollars. And therefore, you're going to see a cost, and it's not going to pass because no one wants to pay for anything. It will be a failure. That's why there's no alternative to an ACA expansion. Okay, the last thing that can be very confusing today that was not confusing 3 weeks ago is something that came down from CMS, Center for Medicaid and Medicare Services in Washington, in response to an application by the state of Texas. Human Services under our Governor Abbott went to Washington, went to the Trump administration and said, the deal we've had, a non-expansion, that's critical, non-expansion Section 1115 waiver that we've had since 2012 is coming to an end. And it was bringing us around $6 billion a year, real money. They went and negotiated, they're calling it an extension, but it's really kind of a new deal that tries to approximate the old deal. It's a good thing in many ways. It does bring us some money that we were otherwise going to lose. It ensures a total of 0 people. So without trying to memorize everything on this slide, if anybody says, hey, we fixed that, what about we just got the waiver, we got that other waiver, it takes care of everything. It takes care of some things. It doesn't insure any people. So it's like 0 people on the one hand versus 1 million people under an expansion. It also doesn't pull anywhere near the same sources of funding. And it also pulls money down at, yep, you guessed it, 60-40. It's a heavy burden. I'm not opposed to it, and no one should be opposed to it. Now, there's all kinds of areas that are undefined and that are untested, and it's fraught with misinterpretation. There's problems with that waiver that are going to have to be worked out if it survives at all. And it was rushed through in a process that the Biden administration could very well reject. Suffice to say that the non-expansion so-called renewal thingy is not a substitute for Medicaid expansion in any respect at all. It may well work quite well as a complement to Medicaid expansion. It might help hospitals and physicians participate in the Medicaid program. It might ensure that we can pay for the uninsured people outside of the expansion population, because we're going to have several million people who still are uninsured. So it's a good thing, and we don't have to criticize it, but what we've got to recognize is at best, it's going to be a complement to a Medicaid expansion. I have listed here 2 other columns about what the non-expansion waiver does not do that Medicaid expansion would do. Over here on the left, I mentioned it doesn't provide insurance, doesn't have that really awesome, generous federal state match rate. It doesn't have the same economic benefits as far as generating revenue. It doesn't reach out to those rural and urban health systems in anywhere near the same way that have such a high rate of uncompensated care. All those benefits that come just aren't going to be there. It doesn't have a separate problem to reduce trips to the emergency room. In fact, it continues the charity model of care for uninsured people. That encourages using the emergency room as your first line of healthcare. It's a fine thing on its own, but it is not a model for treating the uninsured by any respect. Now, where it gets a little confusing is the 1115 non-expansion waiver. I've got an 1115 expansion waiver on the table. Expansion versus non-expansion. The 1115 waiver I'm proposing has that same 90-10 match. It covers that whole population, but it also does a bunch of other little things that we'll run through that should draw bipartisan support and perhaps have some very good effects outside of simply providing insurance to people. And since that's summarized later, I'll skip that part of the column. Medicaid misunderstandings, misinformation. I don't want to run through all of these. I'm not sure there'll be a Q&A, just suffice to say it's here. If you want to look at it, I can send this out. There's a lot of things people think that are false. I'll give you one example and we'll move on. Frequently people will say, well, it's a good deal until they take it away. And that has 2 variants on it. One is, people believe that the federal match to Medicaid expansion was structured to go from 100 to 90 to 80 to 70 on down to 0. That is false. It wasn't and it isn't. It is fixed at 90 and that's where it will stay. The other variant of that argument is, yeah, but once we become dependent on that and the federal government pulls it away, we're stuck. Now, I'll address that later. That's not going to happen either. So let's look at politics in the future Medicaid expansion. Since I just brought up that drop to 0, 38 states have expanded Medicaid so far, either through that direct, simple, traditional Medicaid expansion or through an 1115, I should say, expansion waiver, like what I've proposed here. The expansion waiver allows us to attract Republican support because it has some elements that have been considered conservative or at least favored in other states. But as for it going away, the Supreme Court generally, it's believed that the Supreme Court will not even attempt to throw out the ACA on constitutional grounds, notwithstanding the idiotic lawsuit that presently is pending before the Supreme Court. There may be a few justices who go with it, but the consensus among jurists is that that is not going to happen. Were it to happen, however, were the United States Supreme Court to topple the entire Affordable Care Act based on one sentence, it's pretty easy for the current Congress and the current administration to fix it. They're going to delete that sentence from the Affordable Care Act and everything's going to be fine. Finally, I don't think anybody really wants this to go away. Anybody in those 38 states, look at how many people that represents. 228 million people are getting money at a 90-10 match pumped into their economies, taking care of their people. 53 million people among that population are enrolled in the expansion population, receiving mental health benefits, receiving primary care, receiving routine health care, going to work, picking their kids up after school, being more productive, happier, effective citizens. Are you really going to go back to your district as a Republican or a Democrat and says, guess what? I've decided to take money out of our economy and make sure that we have more people without health insurance. I don't see it happening. The program I've proposed is a Medicaid expansion. But if people don't like the word, you can say this is not, I think it's even a good starting point if you're trying to convince somebody, right? Say this, by the way, is not that old Medicaid expansion you've seen before. It's not just that giving away money to people, whatever. And it's not. That's important because this is specifically, strictly speaking, an exemption from traditional Medicaid expansion rules. We are drawing down that same money with a different set of rules, customized to the state. It exists in the form I filed it right now. If we move forward with this, it's not going to look the same at the end of the process. It will be more customized to Texas with more input from people around the state. But it's a good starting point. It does point number one, it picks up everybody we talked about at that match we talked about. There's an individual, I like to call it agency. A buzzword among conservatives tends to be individual responsibility. But I like to think of it in terms of asking people and enabling people to take agency in their own healthcare. We've created a health savings account with copays and cost sharing, just like you have in private sector employment in many instances. These are indigent people that can't afford the copay of a high deductible plan. The state funds their health savings account to start with. And if they make contributions to that on a monthly basis, they get extra benefits, dental, vision. Moreover, if they get a job that pays too little for them to be able to afford health insurance, that employer can contribute to their health savings account. If they get a job and they're worried about losing their health savings account, the plan will ask them to take some of the money with them. We don't want disincentives for employment. And in fact, we are going to encourage employment because participants in the expansion population under this plan will be referred to the Texas Workforce Commission, which will try to partner with other agencies or non-governmental agencies, organizations, to provide job counseling, job seeking assistance, that sort of stuff. Some people don't like this. If I can get Republicans to expand Medicaid by having people go to job counseling, I think it's a pretty good deal, personally. Some people hate this element of it. I think that we've got to have a much more serious, sober attitude about this. And it is good to get people working. We want that to happen. Work requirements? No, they don't work. Empirically, they don't work, and they're unconstitutional. So this is one of those areas designed to pull bipartisan support together. And the evidence out on this is that it works pretty well. It's not kicking people out. That's important. I mentioned the enhanced benefits, social determinants of health, concept that's very common these days, meaning generally there are things like interpersonal violence, adequate nutrition, access to transportation, proximity to pollution, these sorts of things that affect your health. They're not traditionally addressed in the healthcare space. Individual private sector insurance providers are starting to understand that investing some of their own profits in non-healthcare things like social determinants of health gives them better results with their patient population, which lowers their costs, which increases their profits. So it's an attempt to harness market sector profit-driven forces to address social determinants of health, which gives people better quality of life and better health outcomes. We got a little bit of that in this bill. I'm working on putting some more in it. And we also have some parallel legislation. Again, a lot of things in legislation work in complement, not just standalone. Other legislation where we continue to incentivize addressing social determinants of health throughout the system. We also do have some difficulty, a challenge in the state with getting enough physicians to participate in the Medicaid program. The MCOs are required to have enough physicians and they do a good job of it. But it's a strain all the time. It's a big strain. And one of the problems is compensation. This plan raises Medicaid reimbursement rates up to parity with Medicare, a pretty significant jump. And that should help with the physician participation. Two other things to note. Texas has a managed care system right now. It was not a laggard in that respect by any means. And we've got a pretty good operation going with that. To effectively have an expansion waiver and do a lot of the things we're trying to do, you've got to have an MCO system set up. Fortunately for Texas, we already do. That's why this is such a good idea for the state of Texas, because we've got the infrastructure in place to handle it. Lastly, going back to our comment about what happens when the federal government pulls the rug out from under us, which it won't, don't worry. There's a self-destruct mechanism built into this plan. If the government pulls the money away, we don't have to do it. The plan blows up. Again, I don't think that happens. We can opt to do it if we want to do it if the government lowers the amount of money, but the conversation in Congress right now is around possibly even raising the 90-10 match to incentivize states like Texas to join in. That's it for the slides and the basic overview. I think it's actually kind of a critical moment right now. We've got the non-expansion waiver out there. We've got Democrats hopeful to pass Medicaid expansion the first time. We got Republicans, some of them saying it out loud that they would support it, not very many of them quietly. The door is not shut. There's pressure to open it up. This is the perfect time to call your legislators, to call your friends in other places, have them call their legislators and say, we've got to have a 90-10 match. We've got to have an ACA expansion. It works for Texas.